Hello everyone, this is Clipper Young here. We will spend the next 3 hours focusing on drugs that we use to treat type 2 diabetes. And the focus is clinical pharmacology. Why do I call clinical pharmacology? Because this lecture is more than just mechanism of action. We will talk about clinical applications of the drugs and the information that we share with our patients to use the drug safely and efficaciously. And there are so many agents. So there's a system that we use to organize all the drugs. And this system is called Omnibus Octet. And I will focus on that a bit later. Since this lecture is really long with about 150 slides, so I've broken this whole long lecture into 3 segments when I'm doing the recording. So let's start with segment 1. Here are the learning objectives. So first, we will focus on an overview of all the medications. Then, of course, we'll talk about the mechanism of actions and how do they fit into this structure called Omnibus Octet. And we want to talk a little bit about the safety and efficacy of using the drugs and the rationales behind it. Then share the important information with our patients. And also with all these drugs, how do they fit into the treatment algorithms? There are 2 big guidelines out there that we use in diabetes. They are American Diabetes Association guidelines and also American Association of Clinical Endocrinologists. So here is the outline lecture. So I've structured this lecture into 3 parts. Part 1, we focus on the pathogenesis of type 2 diabetes. Then we move on to talking about the agents by class and also by specific agents. Then part 3 would be the clinical guidelines. How do we diagnose type 2 diabetes and what is the goal of treatment and also the algorithms. And I'm sure Dr. Schubert has talked about this, so I won't spend a lot of time, but I just want you guys to get a sense of how do all this drug fit into the treatment guidelines. So let's get started with our background to diabetes. So when we talk about diabetes, think about it is a continuum because diabetes really is a progressive condition. So we will start off with our normal glucose level. But then there are some factors that might change our normal glucose level. So they can be external factor like the environment that might lead to obesity or lack of activity, lack of physical activity, or aging. And it could be a factor that might lead to increasing of sugar level in our blood. Then eventually that might lead to prediabetes. Or the second factor is genetics. So for example, African American or Asian Americans, they are at a higher risk of developing type 2 diabetes. Then if at the stage of prediabetes, the sugar is not controlled, then it will progress to type 2 diabetes. And as I mentioned earlier, this is a spectrum. So what is wrong? There are a few factors that we look at. So insulin resistance, that means our body is not responding to our own insulin. Or maybe there's something wrong with the pancreas. And to be even more specific, beta cells, they stop producing insulin. And at some point, if many of the beta cells, they fail to produce insulin, and then we will get to type 2 diabetes. However, type 2 diabetes is more than just the pancreas. The liver also plays a role when it comes to type 2 diabetes. So because the liver just keep producing sugar nonstop, so that will also lead to um, progressively increase in glucose. So if type 2 diabetes is not controlled, then eventually it will lead to all kinds of complications that you might heard of. Um, Here are the examples: stroke, myocardial infarction, blindness, kidney conditions, and neuropathy. So that's the reason why it's so important to control our glucose and to prevent all these complications. So as I mentioned earlier, there's a structure that we use in explaining the causes of hyperglycemia. So, and this structure is called omnibus octet. And when we talk about omnibus octet, what we're really focusing on it's the core defects in type 2 diabetes. So there are 8 octet, right? So let's start with the pancreas. So the pancreas, there are the types of cells that we focus on are alpha and beta cells. So for alpha cells, when it impaired, when alpha cells is impaired, it will have an increase in glucagon secretion. When the beta cells are impaired, then there is a decrease in insulin secretion. So the next organ is the gut. So there is, and you will see a decrease in the incretin effect. So I will talk about this in a bit. The next is adipose tissues. So we will see an increase in lipolysis, so breaking down of fat. Our kidneys. So there will be an increase in glucose reabsorption in the kidneys, and which then lead to a higher glucose in the blood. The next organ would be our muscles. So to be more specific, our skeletal muscle, that you will see a decrease in glucose uptake. The next is our central nervous system. So we might see some neurotransmitter dysfunction, which then would lead to hyperglycemia. And our last organ is our liver, as I mentioned earlier. And you will see a more glucose being produced from the liver. And ultimately, all these components will lead to hyperglycemia, which is what we see in type 2 diabetes. So in the nutshell, there are multiple core defects that will impact the development of type 2 diabetes. And because there are multiple core defects, and when it comes to treatment, and we will need a combination of drugs to help hopefully manage the condition. So the key here is to treat as early as possible, to hopefully slow down the progression of the condition and to prevent complications. So how do we do that? So there are many drugs that have been produced to achieve this goal. And we divided all these drugs into 7 main classes. But under each class, we have some sub classes. So first, we will talk about insulin sensitizers. There are biguanide and thiazolidinediones, also called TCDs. And we also have insulin secretagogues. We have sulfonylureas and meglitinides. And next, this is a newer pathological pathway called the incretin-based agents. There are 3 subclasses. DPP-4 inhibitors. So DPP-4 stands for dipeptidopeptidase 4 inhibitors, GLP-1 receptor agonists, glucagon-like peptide 1 receptor agonists, amylin mimetic, and the next class would impact our kidneys. So they're called SGLT2 inhibitors. SGLT2 stands for sodium glucose transport 2 inhibitor. So the next class would impact our gastrointestinal tract. There are two subclasses called alpha glucosidase inhibitors and also bile acid sequestrant or resent. And the next class would impact our central nervous system. And it is dopamine 2 receptor agonist. And the last, of course, insulin. Okay. So let's get into the meat of this lecture, the diabetes agents. Okay. So again, here are the different classes, and we make some symbols to distinguish the oral form. So if you see pills, that means they're oral. And if you see a syringe, that means they're injections. So as I mentioned earlier, we use Omnibus Octet as a way to help categorize all the different types of medication, different classes of medications. So, but I will touch on every single one later on. So this slide is very busy. So this, I just want you to give you an idea of for each component of the octet, there are medications to target it, and hopefully that will reach the goal of managing diabetes or reduce glucose in the blood. So let's get into our first class called the insulin sensitizers. So they are biguanide and thiazolidinediones or TZDs, and collectively what they do to lower the glucose would be first to increase the skeletal muscle and the adipose tissue sensitivity to the insulin. So sensitizer, right? So make insulin more sensitive to the specific tissue that would be adipose tissue and the skeletal muscle. And secondarily, it would help to reduce the liver by pumping out to reduce the liver to produce glucose. So collectively, as I mentioned earlier, there are three pathways or three core defects that these two classes of drugs that would target: the skeletal muscle, adipose tissue, and the liver. So let's get into biguanide. So I'm sure many of you heard of the drug metformin. So which is biguanide. The primary mechanism of action is to reduce the hepatic glucose production. So how does that happen? So metformin would increase the activity of a kinase, and specifically it's the AMP-dependent protein kinase. So after the activation is started, then we will see the increase in fatty acid oxidation, and we will see the reduction in lipogenesis. And also, we will see, this is the important thing, our muscle will take in more glucose, then will reduce the sugar. And also this, the last one here, will reduce the gluconeogenesis, meaning to reduce the production of new glucose from the liver. So what's the results? Of course, then we have less amount of glucose being produced from the liver. And also, as I mentioned earlier, insulin that would help to increase insulin sensitivity, specifically in our skeletal muscle and also in our adipose tissue. Then we will also see glycogen storage increases in the muscle, and we will have a lower glucagon level, and also there's a lower intestinal glucose absorption. So other than that, metformin also acts on the cell membranes by having more glucose being transported into the cell. So that means they will have less glucose molecules floating around in the blood. So the great thing about metformin is it does not lead to insulin secretion. So that means when patient takes this medication, we would expect limited to no hypoglycemia. So this is very important. Okay, so metformin is used as a first-line agent to treat type 2 diabetes, unless it is contraindicated. So, and again, this medication do not predispose patient to hypoglycemia. We generally consider this drug as weight neutral, so it does not increase or decrease patient's weight. However, there might lead to a little bit of weight reduction that we saw in some patients. So in terms of the glucose reduction effect, so metformin would impact fasting blood glucose more than it does to postprandial blood sugars. So in terms of side effects, so mostly we will see some gastrointestinal upset. For example, nausea, vomiting, diarrhea. And some patient might complain about having metallic taste. So if that happens, there are several ways that we can fix it or we can prevent it. So first, we want to start the medication slow and titrate slowly. So what do I mean by low? So we will start at the low dose 500 daily, then increase to 1,000 milligrams daily, then increase to 2,000 milligrams daily, which is the max effective dose. So if a patient comes into you and complains about having diarrhea and vomiting from taking metformin, then the solution might be just change the formulation to an extended release formulation. So there are two forms, either the ER or the XR. So when we dose the extended release formulation, this is a once daily dosing that we usually ask the patient to take it before dinner and with food. There are, and also the other serious but rarely happen side effect is lactic acidosis. So for those whose kidneys are not working so well, that might increase the risk of lactic acidosis. So for this reason, whenever we initiate or we want to titrate the dose, we always need to check patient's renal function. And the other side effect would be there might be a slight decrease in patient's vitamin B12 level. So we might have to check patient's level after starting metformin. So safety concerns. We might need to for example, when patient is hospitalized, we will want to stop metformin. Or before patient needs to do a contrast media, like for example, imaging study, we will need to stop metformin for a while because that might increase the risk of lactic acidosis. So what are some warnings and contraindications? So if the patient is in acidotic state, we don't want to continue metformin. If patient has a chronic liver function problem, we don't want to start metformin. Any history of lactic acidosis, if patient is an alcoholic, and we need to pay attention. And also, if a patient has chronic heart failure, a class 2 or 3, no, class 3 or 4, and we want to stop metformin. So there is a new update in regards to the renal function and also metformin use. So when patient's eGFR is lower than a 30, metformin is contraindicated. So we will need to stop. So when patient's eGFR is between 30 to 50 or 45, then it depends. So if the patient is already on metformin, then we will need to reduce the dose. Or if the patient has never been on metformin, then when their renal functions gets this low, we will not want to start metformin. So again, the key thing here is we will need to check eGFR before metformin initiation or titration. So metformin, there is about 1% to 1.5% A1C reduction. And as I mentioned earlier, primarily it will help with the fasting blood sugar reduction. So the dosing, we can dose up to 2550 milligrams daily, which is 850 3 times daily, but we don't really push to this high of a dose because we might not see any benefit, and what we get would be more side effect. So for that reason, we usually keep the max dose 2 grams daily. So what are some advantages and disadvantages of metformin? And here is important. So because this is an insulin sensitizer, it does not push the body to produce more insulin. So we don't have to worry about hypoglycemia. So and this medication is considered weight neutral mostly. And there were some studies showing that metformin can improve micro and also macrovascular outcomes. And this medication is really cheap. In terms of disadvantages, so initially, patients might get some GI upset, like vomiting, diarrhea, or this medication is renally, so as I mentioned earlier, if the renal function is low, we need to be careful. And if it's really low, we need to stop the medication. And we've seen some secondary failures. So that means some patients might not respond to this medication. So the next class is TZD, thiazolidinediones. So how do they work? The exact mechanism of action of TZDs, we don't really know, but we think that impact glucose and lipid metabolism at the gene level, so genetic level. So they bind to a nuclear receptor called PPAR gamma. So PPAR stands for peroxisome proliferator activated receptor gamma. And this this receptor here would regulate the gene expression, the gene transcription. So, and it would impact at least at 3 levels. So level 1 would be at the adipose tissue. So it would reduce the flow of fatty acid into the muscle. So that will help to reduce the insulin resistance. And secondly, it will impact the expression of certain protein that might impact the insulin resistance. So, and the next thing is that will help to reduce the lipolysis and also help reduce a redistribution of fat. And the second organ that TCD might impact would be the skeletal muscle. So it will ultimately would help the increase of glucose uptake by increasing the synthesis of a glucose transporter. So then this glucose transporter is number 4, which is insulin dependent. And the last impact would be to reduce the hepatic glucose output. So by reducing the liver to produce glucose. So there are 2 agents in this class. The first is pioglitazone. Also, the brand name is Actos. And the second agent is rosiglitazone. The brand name is Evendia. So as I mentioned earlier, they help reduce insulin resistance, and specifically in the peripheral skeletal muscle. And this is very important. The next point is very important to share with your patient. It has a slow onset of action. It will take about 4 to 12, even 12 weeks to see the full effect. So if you start this medication for a patient and he or she comes in to you saying that this medication doesn't do anything, then you might want to explain to the patient that it will take a long time to have the effect. But once it works, it can work for a very long time, because this medication can prolong beta cell survival. And in addition to lowering glucose, pioglitazone can also lower triglyceride and also increase HDL. So for those who also suffer from hyperlipidemia, pioglitazone might be a good option for them. So what are some side effects? The big thing that we see is fluid retention. So that might lead to edema, especially lower extremity edema. And for those who have congestive heart failure, we don't want to use this medication because it might make the case worse. And weight gain is another side effect. So in terms of warning, so for those who have liver problems, we want to avoid this class altogether. And there are some studies show that for those who this medication can increase the risk of bone loss, and that would cause a fracture. There were a lot of studies on and off saying that there's association between pioglitazone and bladder cancer, but there is some mixed data. So that's why FDA is still reviewing which is true. And also for rosiglitazone, back in 2008, there was a study came out saying that there was an association between the use of rosiglitazone and the increased risk of cardiovascular risk. But actually, there is a black box warning placed on rosiglitazone. But the good thing now is the restrictions have been lifted. And as I mentioned earlier, so for those who have congestive heart failure, TCDs is not a good option. So in terms of A1C reduction, you might see as high as a 1.5% reduction, and this is similar to metformin. So primarily, this TCDs would reduce fasting blood glucose. It might also impact postprandial glucose, but not as much as impacting the fasting blood glucose. Okay, so in terms of dosing, so the important thing here is the max effective dose it's recommended to be half of um, the recommended dose by the manufacturer. So that means to initiate, of course, you want to start low, but you might not want to prescribe more than 30 milligrams of pioglitazone because we might not get the benefit. But what we might get more is the side effects. So for rosiglitazone, and we might want to just start at 4 and just leave it there. And what are some advantages? So same as metformin. So there's a limited to no hypoglycemia, and specifically for pioglitazone, um, it helps to reduce triglyceride and also increase HDL. And pioglitazone can also prolong beta cell survival. We don't need to do any renal adjustment for these disadvantages. So we need to watch for weight gain, and there's might be a risk of high risk of getting fracture, um, heart failure exacerbation, and pioglitazone has been associated with bladder cancer. However, as I mentioned earlier, the data is mixed. So there are studies going on to to find out what the truth might be. And for those whose liver is not working so well, we might want to avoid this medication. So let's review the key concepts of insulin sensitizers. So there are 4 questions. And also at the end of each big class, we will have this review slides for you to gather the main points. So the first question is, where do the agents exert their effect? What is the mechanism of action? Question 2, what is the major benefit of these agents? Question 3, what are the major precautions of metformin? Question 4, which class may exacerbate congestive heart failure and is associated with bone loss and hepatotoxicity? So I will give you 30 seconds to think about the answers to each question. You might want to write it down. Okay, are you ready? So for question 1, what do the agents exert their effect? So there are 3 core defects that we mentioned earlier. They are the liver, skeletal muscle, and adipose tissue. So what is the mechanism of action? So they both reduce the glucose being produced by the liver, and also they both increased the insulin sensitivity. Question 2. What is the major benefit of these agents? So the good thing is they both have limited to no hypoglycemia, and also no weight gain, but only for metformin though. So this no weight gain only applies to metformin. The TZDs, they do cause weight gain. So what are the major precautions of metformin? So for metformin, so we need to worry about lactic acidosis, especially for those whose EGFR is lower than a 30. So, and also for those who have class 3 or 4 congestive heart failure, we will not use metformin. The last question, which class may exacerbate CHF and is associated with bone loss and hepatotoxicity. So they are the TCDs, pioglitazone and rosiglitazone. Okay, so let's move on to the next big category. They are the insulin secretagogues. So they are sulfonylureas and meglitinides. So how do they work? They work by stimulating the beta cells in the pancreas to produce more insulin. So that's why you see beta cells here as the core defect that insulin secretagogues in. So let's start with sulfonylureas. Sulfonylureas directly stimulate beta cell to produce insulin. So how do they act? First, so let's take a look at this diagram here. So first, sulfonylurea would bind to this receptor, so called the sulfonylurea 1 receptor on the potassium channel, which is ATP fueled. So, and once the sulfonylurea binds to the potassium channel, then we will see a decrease in potassium going out of the cell. With less potassium ions going out, then we will lead to depolarization. And with depolarization, then we'll have more calcium ions coming into the cell. And do you remember the function of calcium ion in terms of in the cell? So they would bind to the vesicles, which has a lot of insulin molecules in there, to fuse with the cell membrane. So once the vesicle is fused with the cell membrane, then we will see a release of insulin. So this process is independent of the glucose level. So that means it doesn't matter how high or how low the glucose level is, insulin is still being produced. And also this mechanism of action will require some remaining beta cell function to work, right? So if this beta cell doesn't work, then the patient will not respond to the sulfonylurea. And that's the reason why that pretty much how this, in a nutshell, how this medication class work would be to keep pushing our pancreas to produce insulin. But but what if a patient has had diabetes for a long time and then keep taking sulfonylurea? And that's the reason why that at some point, maybe 5 years of being on sulfonylurea, they start responding because the pancreas is burned out. Okay, so this is another diagram illustrating the same concept. So first, sulfonylurea would bind to the potassium channel. With the potassium channel, then there won't be as many potassium channel going out. So that would then lead to depolarization inside of the cell. With a depolarization, that would lead to more calcium ions coming into the cell. With more calcium ions, then that will bind to the vesicle with insulin in them to facilitate the fusion of the vesicle to the cell membrane that will lead to the release of insulin. So, and also with this higher potency of binding to the receptor, and the impact or the effect is more predictable in terms of the onset of action and also the duration of action. So, as I mentioned earlier, um, even though compared to the first generation, it's a lower hypoglycemia, but hypoglycemia, it's still a risk, especially when patients' kidney functions um, were low, and weight gain is one of the side effects because we keep pushing the pancreas to produce more and more and more insulin, and the insulin is a growth hormone. And there are other side effects, but they're not as common. So some patients might develop rash after taking sulfonylurea, or some patient might express they're sensitive to light. So what are the warnings and contraindications? So mostly, if we can, avoid glyburide, except glyburide is used in pregnancy. And the ADA actually listed glyburide as contraindicated in the older generation. Well, the reason is glyburide has a long-acting active metabolite, which is cleared by the kidney. So for those who are at the older generation, their kidneys they might not function as well. So that might lead to the higher risk of hypoglycemia. So then instead, we want to use glipizide or glimepiride uh, in the elderly population and also in those whose kidneys are not working so well. And for those who are allergic to sulfonylurea, of course, we don't want to use it. And in speaking of allergies, so so if you take a look at this molecule right here, which is glipizide, it contains sulfa. So for those who have sulfa allergy, we do not want to use it. And for those who experience DKA, or there's some really reoccurrent low hypoglycemia, we want to avoid using sulfonylurea. And this is not a drug for type 1 patients because in order for this drug to work, we rely on some function of the beta cell. So if and for type 1 patients, as Dr. Schubro mentioned in his lecture, type 1 patients, they do not have the ability to produce insulin. And lastly, for those who have cardiovascular conditions or who have renal conditions, we would want to avoid sulfonylurea. Okay, so in terms of dosing, the in the nutshell, so what you see here, the daily dosing for glipizide would be the max dose would be 40, glyburide the max dose would be 20, and glimepiride the max would be 8. However, when it comes to the max effective daily dose, it's half of the manufacturer recommended. So that's important because we don't see more benefit beyond the max effective dose. So in terms of A1C reduction, so we might see as high as 1.5% reduction. And for sulfonylurea, it will help to reduce fasting blood glucose as well as postprandial. So what are some advantages? So it acts really fast, and this class of medications is very cheap, and high initial response rate. So patient do respond to this class of medication initially. So what are the disadvantages? So we need to watch out for hypoglycemia, and we need to watch out for weight gain, and also it has high secondary failure rate because, as I mentioned earlier, this class of medication just keep pushing the pancreas to produce insulin, but at some point the pancreas is going to burn out. Then they don't respond to this medication. The next insulin secretagogue class is meglitinides. Are meglitinides. So how they act is very similar to sulfonylurea. That's why that you do not want to use sulfonylurea with a meglitinide. And we also call meglitinide as the prandial secretagogues because they work very, very similarly. So which I won't get into it. But the difference would be the difference between meglitinide and sulfonylurea would be meglitinide. They are way faster in acting or to have a onset of action, and also, but then they work and the duration of action is actually shorter. So that's the reason why that you want to take this medication before meals. And also, it is used to reduce the postprandial glucose high. And so this point here is important. So for those for patients, if they have irregular meals or if they have some liver dysfunction, and meglitinides might be a good choice. So, so there are two agents in this class. So they are nactaclinide, the brand name is Starlix, or repaclinide, the brand name is Prandin. So the instruction is to take this medication 30 minutes before a meal because the target is to lower the postprandial blood glucose. So the difference between the two is for nactaclinide, it has a faster onset of action, and for repaclinide, it has a longer duration of action. So similar to sulfonylurea, they do induce hypoglycemia and also induce weight gain. And for warnings and contraindications, so do not use repaclinide with atrial fibrosing because they have drug-drug interaction. And similar to sulfonylureas, so for those who have recurrent severe hypoglycemia or DKA, type 1 diabetes, renal function decrease, or cardiovascular outcome, we want to avoid meglitinides. For meglitinides, you might see as high as a 1.5% A1C reduction. And again, so meglitinide would specifically target postprandial blood glucose. So in terms of dosing, we will have to dose meglitinide 3 times or 4 times a day. So depending on the medication that you use. So what are the advantages? So compared to sulfonylurea, so meglitinide, they have a faster onset of action. We don't need to worry about sulfa allergy, and also it specifically target meal blood glucose, and for disadvantage, so same as sulfonylurea. It will cause hypoglycemia. It will cause weight gain, and also you will see secondary failure because these medications would push the pancreas to produce more insulin, but then eventually the result is to burn the pancreas out. And the other disadvantage would be we'll have to dose the medication more frequently. So we are reaching the end of insulin secretagogue. So let's review the major concepts. So question 1. Where do the agents exert their effect? What is the mechanism of action? Question 2. What are the top 2 major side effects? Question 3. Which agents have rapid onset, short duration, and should be taken immediately before meals to control postprandial blood glucose? So I will give you 30 seconds to think about to write down your answers. Okay. So, question 1. The answer to question 1 is, what do the agents exert their effects? So they exert their effect in beta cells of the pancreas. So what do? So what is the mechanism of action? So they stimulate beta cells to release insulin. And however, but the bottom line is it requires some baseline functioning of the beta cells. Question 2. What are the top 2 major side effects? So they are hypoglycemia and weight gain. Question 3. Which agents have rapid onset, short duration, and should be taken immediately before meals to control postprandial blood glucose? That would be meglitinides. So if we plan to skip a meal, then we would want to skip the dose. Thank you for listening. The end of segment 1.